get going?
Yeah, have done now, Chair.
Okay, well, welcome, ladies and gentlemen, to this, our July board meeting of South Warwickshire NHS Foundation Trust. Just before we get into the agenda, just three things I want to brief you on. The first is that due to some technical issues, we're having to cancel tomorrow's annual general meeting, and that will be rescheduled to later on in the year, probably towards the end of September. So I apologise to members of the public who'd arranged their diaries to make themselves available for our annual general meeting, but we will get there. It will just be a little bit later. The second was, as you know, SWFT is part of the foundation group, and at the weekend we lost a dear and beloved colleague of ours from Wye Valley Trust, Howard Oddie, who was the finance director in Wye Valley for many years. Everyone on the board will have met him at the three boards meetings. He was an exceptionally kind and generous and decent man, and I know the team down there are mourning the loss of Howard, and Glenn and I were close to him as well, so I'd just like to reflect on and give thanks for Howard and his work. The third was, in terms of the workshop this morning, we had another update on our safeguarding and a safeguarding trading session. The board, in between the board meetings and the board workshops, have been having substantial workshops on equality and diversity, and so that built into that. We had an update on the electronic patient record work, which is going on behind the scenes. We had a fantastic update on digital innovation, and Adam Carson inspired the board with some of the great work that's coming along generally from our digital colleagues, but particularly out of the Digital Hub. So a really good session. So we have a full board. We have apologies from Charles Ashton, but we're pleased to have Scott Sanders with us today, and we have apologies from Sarah Collette, the Trust Secretary. Are there any new declarations of interest? Please raise a digital hand if there are. Okay, I can see no digital hands, so I assume not. The last set of minutes of the meeting held on the 2nd of June. If you have any amends to those minutes, could you please raise a digital hand? Okay, I can see no digital hands, so we'll go to the matters arising, which is on page 16. The first matters arising were on the integrated performance dashboard. The first that Fiona would include mental health information for children and adults within future reports. You've done that, Fiona, so thank you. The second was that Helen would ensure the missed opportunity audit be brought back to the board in June. That was done, but it's included in the bed modelling work. Is that correct, Helen? Yes, Helen, thank you. And then on clinical governance committee, Glenn, to keep the board appraised of the progress with the CWPS network meeting. Glenn, you and I actually have a meeting on Monday with colleagues from UHCW, which I'm sure will pick up on that, but anything else you wanted to add here?
In fact, my update was going to be, there's been no meeting of the network, but we are meeting with the Chair and Chief Executive of UHW on Monday, so we will raise the concerns of the board. We've not had one of those meetings for a while. That's great, thank you, Glenn. Then on the board assurance framework, trust-wide oversight of work streams, risks and mitigations to be held in September, so looking forward to that, Anne. Black Swan event training also to occur, that's being arranged for next year, so thank you. Then Helen, to ensure the point prevalence survey outcomes be brought back to the board in July or August. I assume that's all on track, Helen. Really important piece of work that, in terms of helping us to identify for the whole of the system, if patients were in their right settings, how much the system could save.
it always ends up with a big number. So looking forward to that. Then the executive team to ensure that non-clinical staff be reviewed on a quarterly basis to see where staffing challenges were prevalent. So we leave that with you, Gertie and Anne, to make sure that happens, please. Then Gertie to include some data within the report around recruitment figures by gender profile, disability profile, and number of people that relates to. We sort of didn't really touch on that this morning, Gertie. When are you sort of hoping to come back more comprehensively on that?
That's in the annual report on today's board, Chair.
Super, thank you. And then Charles to bring back the medical revalidation report in November. So that's a missed bullet, Scott. So look forward to that, Charles. Then Gertie to invite 2 members of the BAME network who'd been allocated places on the National Res Expert Programme to attend a future board workshop. Gertie, that was scheduled for the board workshop today, but the Res Programme has been put on hold anyway.
It remains on hold, and we hope it'll start in the coming few months, and obviously we will then link our colleagues back into a board workshop in future, particularly with some of the board development as well.
Great, thank you, Gertie. Then Fiona to ensure an update on the recommendations following the Ockington review be brought back in August. We'll touch on the CNST report a bit later, Fiona, but that's in train, thank you. Then Kim bring the second half of the plan once those details have been confirmed. Hoping to do that in September, Kim?
Yeah, I'll bring something hopefully for the August meeting as well, and confidential, to discuss the various options, but probably the formal plan in September. Thank
you very much, Kim. And then Sue Pike to ensure the registered nurses and midwives, minute isn't very elegantly worded on this, it says be broken down, but be put into 2 separate groups within the Who Was Speaking Up profession graph. So I'm sure that will happen for September. Are there any matters arising that I've missed? Okay, so I referred to the clinical negligence scheme incentive scheme report. Fiona, over to you, please.
Yeah, thank you, Chair. So this is our annual board declaration of compliance against the CNST clinical negligence scheme. It's 3 years in running now. The requirements of the CNST change each year, and in my opinion seem to be getting more complex and more and more of a requirement each year. We are declaring compliance with 7 out of 10, and you can see that in the report. And I just want to go into a little bit more detail against the 3 non-compliant areas, if I can. Actually, can I just refer back to the title page where Sarah Noble is the report author? That is an error, actually. Sarah isn't available in practice at the moment, and this report has been pulled together by Rebecca Talbot as the governance lead in maternity, and I thank her for the robust evidence that she's pulled together. This is a task and a half every year, and with Ockington on top, which is very similar in terms of the level of requirement of submission. It's been a task for her, so I applaud her for doing that. So going back to the 3 areas of non-compliance that you'll see is safety action 3, 5 and 9. And I just do want to reassure the public and assure the board that although we're declaring non-compliance, we have moved and implemented a number of elements of these 3. But in the same way as Ockington, the maternity team self-assess themselves quite harshly, and if there's any element that we can't evidence, then we have put ourselves as non-compliant, and the board has steered maternity team to do that, to self-assess them harshly, to set the bar high, and to make sure that it's really robust in its evidence. So again, I applaud them for doing that, but just to make sure that the board know that there's limited safety concerns associated with these, and I'll go into that. So safety action 3 is around demonstrating that the trust has a transitional care unit, and transitional care is a model that is used in a different ways across the country, but generally means and is focused on reducing the time that a mother, a parent is separated from their baby postnatally. And that can be for a number of reasons. One is the length of stay in special care if they have required special care from birth, or actually a readmission into special care because they become sick postnatally. And that separates the mother and the baby for a period of time. The LMS locally and the ICS maternity system have differing views on transitional care, and the traditional model of having a high care system in maternity for these babies to reduce that length of stay in SCBU is not widely supported as a model of care, and so hasn't been supported by our commissioners, and there are varying views across the country as to whether this action will even be in the CNST next year, because there is a change of evidence around it. Locally, our commissioners and the LMS have decided on a different model, and that is to introduce a neonatal outreach team that is based in the community and supports a reduction in length of stay for neonates to be returned home with their baby with additional support of neonatal nurses. That's been an initiative that is being led by UHCW, but in partnership with ourselves and George Eliot, and will be implemented this year. So at the moment, we don't have a transitional care unit, but that's the background behind it. And I think that is a better model to support patient safety in the future. And as I say, the Associate Director of Operations and the Head of Midwifery believe that this action won't be required next year for that reason. Safety Action 5 is about demonstrating that we have a robust process in place for ensuring midwifery staffing is safe. And you'll see in the paper, and this is a summary of all the evidence and work that we've done, as you can appreciate, that we've moved safe staffing and midwifery forward in quite a number of steps. We've introduced and reassessed ourselves against Birth Rate Plus and invested in midwifery staffing on the back of that. And we now, in the last year, do an acuity review 3 times a day in labour ward to ensure that the acuity and number of mothers and babies is assessed on an ongoing basis. The only element that we are non-compliant against this action, and there are a number of requirements within it, is that we can't demonstrate that the coordinator in charge of labour ward is supernumerary 100% of the time. The main cause of that is that when we have an obstetric emergency that requires a cesarean section, the coordinator of labour ward is often required in theatre to support with that emergency cesarean section. Our model at the moment means that the theatre teams support that obstetric emergency, but they do require a midwife to support them as well. The emergency, the elective division and women's and children's are working up a case to support that to be a different model in the future, and the head of midwifery is just developing that business case. The exec team is yet to see it, but and it has been delayed slightly because of her absence. But that's the plan, and actions being taken against that. And then thirdly, the Safety Action 9. is, again, we can demonstrate a number of actions that have been taken in the last year about that, and 2 of the non-execs are now nominated non-exec safety champions, and I am the executive safety champion for maternity and obstetrics. We visit and meet the team on a regular basis. Unfortunately, it's slightly home goal here that the visits that I do on a monthly basis to the team to talk to the midwives about what's worrying them and concerning them from a safety point of view hasn't always been developed into an action plan. I've always fed back to the senior team what those themes are, but we haven't been able to demonstrate that we've actually pulled those themes robustly into an action plan. So we'll definitely do that going forward. So in summary, what we're declaring is compliance of 7 out of the 10 safety actions, with 3 of them being compliant in some elements but not others. I'm asking for approval for the board for this to be submitted as our self-assessment and the content shared with our commissioners.
Thank you very much, Fiona, and it's good to have such a transparent report. Bruce Paxton and I are the 2 non-exec safety champions, just so everyone is aware. And can we put on record our thanks to Rebecca, because she has worked phenomenally hard on all of the various different things we're being asked to produce at the moment, and we hope Sarah Noble recovers soon because her team needs her. So questions and perspectives, Glenn?
Thank you, Fiona. I mean, obviously we've got a very well respected maternity service here, and we should be proud of what they do. And I think it's really a good demonstration of their approach to safety that we are self-critical in the way that we complete these self-assessments. Are we being a bit too tough on ourselves? That would be my question. So particularly around number 5. Because obviously there's a full requirement there around safe staffing, and we certainly have a process in place for that. Are we saying that unless we are 100% of the time supernumerary midwife spare, we'll continue to fail that particular element, even though we've got all those other measures in place? Yeah,
unfortunately, there's not a partially compliant option in this, Glenn, as there are in some others, and at the moment, there appears to be no wriggle room, which is a very high bar. I think if it was the odd occasion caused by emergency leave, such as sickness or on the day, then I would be happier to approve that it's our model is correct. But whilst we are supporting obstetric theatres on a fairly regular basis, actually, then I think we are safer to declare it this way.
Thank you, Fiona. Thank you, Glenn. And Rosemary?
Yeah, and on a similar theme to Glenn, I just wonder whether it's worth us doing some covering letter explaining, why we do consider ourselves to be safe in those areas, to really reflect that. Because when we're talking about the pounds and pence, I've just been looking at the papers here, and the maternity incentive for the current year, it might have been slightly less for last year, is £313,000. It's not an insignificant sum, and our total maternity costs are for claims is £3.5 million, which is about £1,500 per birth. These are big numbers. And we focus on being safe, and I just don't want to feel that we're losing out because of our complete openness, which is right. But I just think there may be a balance to get a covering letter to the CNST might help.
That's a good idea. Thank you, Rosemary.
Okay.
We'll leave that with you. So any other comments? Otherwise, so we do need to approve this team. So subject to Rosemary's helpful suggestion, If you're not happy to approve, please raise a digital hand. Duly approved. Thank you, Fiona. And like I said, please thank Becky in particular. Chief Executive's report, Mr. Burley.
Thank you, Chairman. I'll just pull out a few highlights from it. I mean, firstly, the statutory inquiry preparation, which any one of us or the organisation could be called to at any point. Just a reminder here that we need to retain records, and we've put those reminders across the organisation. I mean, part of this is just remembering what the rules were at the time when things happened over the last year. But I'm sure we're well prepared to give evidence if we needed to. Then I talk about inequalities, deprivation and rurality, and I won't go into all of that report, but I think particularly the emphasis here that there is deprivation in rural communities and in to some extent which are more extreme than sometimes in some of the inner city areas. So if you look at the combination of multiple inequalities, so if you look at the age-related need, so I quote here that people who are over age 60 are 5 times more likely to need a CT scan. If you add to that the implications of poverty, and there are more older people living in poverty in Warwickshire than there are in Coventry, mainly because of the very large numbers of older people in Warwickshire. And then also add into that the distance to services, which is another deprivation indicator. And you add those multiple deprivation indicators together, and you start to see why we do need to ensure that we invest in local accessible services. And that kind of mindset is what helped us to tailor the community diagnostic hub bid that we've just put in for Coventry and Warwickshire. And within that, we will be continuing to invest in the community diagnostic hub in Stratford-on-Avon, as well as obviously continuing to have access at Warwick. But it's been a great pleasure to have an expert amongst us. So Duncan Vernon, our public health consultant, has really helped us to get our heads around this. And I think as we move forward and take on that role of lead provider at Place, it will be so important for us to start to look at a needs-based rather than a demand-based model for the way that we deploy our services. So hopefully you enjoyed that section. And then at the end, I give an update on ICS guidance. We have a new Secretary of State, but the guidance has now started its progression through Parliament. So we are still expecting that legislation to be live from April 2022, and locally there's some various manoeuvres to put that in place, and there's further guidance that is due to be published over the coming weeks. And then finally, on some of our teams, I feature here agile working, which is something that we've obviously implemented over the last year in a much bigger way than any other previous year. And we've had a agile working implementation group who've met virtually to look at how we can tailor our approach to this. I mean, obviously we've needed to because of COVID, but as a flexible employer, it's really helped us to offer a more attractive proposition to new staff in many cases. And I saw someone on Twitter actually this week saying about how they were really benefiting from the flexibility that we'd offered as an employer, which has helped us to continue to deliver services despite some of the challenges of the last 12 months. So that's all I wanted to highlight. Happy to take any questions.
Perfect. Thank you very much, Glenn. Any questions or perspectives to Glenn? Glenn, I'm aware there's been some efficiency data produced recently, comparing ourselves with other organisations locally and further beyond. What's that suggesting about our relative efficiency?
Yeah, and I hope we feature and focus much more the productivity, the relative productivity of providers. So, to an extent over the last year, because of the way COVID funding has been managed, we've lost a lot of the grip on that. There's two main ways of demonstrating that. Firstly, there's the model hospital data, and then secondly, there's what's called reference costs, and those were recently updated. Our reference costs continue to be some of the best in the NHS and have improved again this year. The model hospital is probably the easiest way to demonstrate the relative productivity of different organisations. So if you look across our integrated care system, what model hospital does is works out the amount of activity you're delivering and standardises that. So what it says for South Warwickshire is that we operate at around £25 million lower than the standard operating cost of delivering that activity. So that we're one of the most productive trusts in the country. Alongside us, George Eliot are £5 million higher than the standard operating cost of delivering their services. That's improved, and I think from what I can see from the indicators for next time, that will improve further, and hopefully with the right side of the line on that one. UHCW are £83 million more expensive than the standard cost of delivery. So that's quite a significant variance. Part of it is due to their PFI, but I think they would probably cite around £20 million of their extra costs associated with PFI. So hopefully there's some things that we can do together across the system to share approaches to productivity that help to improve that over the years.
Sounds like lots of big opportunities out there. Colleagues, happy to move on? That's great, thank you. So we'll get the introduction to the Integrated Performance Dashboard from Anne. Anne.
Thank you, Chair. When I reviewed the commentary from my colleagues on the Integrated Performance Dashboard, I was struck by 4 things, really. Our teams continue to contend with the COVID-19 recovery in its many guises. We're noticing this increased use of health services, and really, the impact of new initiatives to address our backlogs, particularly on our elective waiting lists. As a consequence, there is emerging adverse impact on clinical outcomes, reducing harm and deteriorating patient metrics, referenced in the Director of Nursing report, which we'll need to monitor closely in terms of its triangulation with growth in our activity. Cancer, there's quite a lot of detail in the Director of Operations commentary, but in summary, it continues to remain challenged. There is positive, renewed, focused work underway, but there is, we shouldn't underestimate the challenge if we were to realise our ambition there to be an exemplary cancer site. People remain at the centre of our business, and the growth in our workforce and the recommencing of international recruitment are positive developments, and we really look forward to welcoming new colleagues in the near future. And finally, I'll leave you with the headline report at the end of month 2 in terms of where we are against our break-even plan. So I need colleagues now to go through in further detail their commentary. Thank you.
Thank you very much, Anne. Colleagues, happy to move on to the detail? Great, thank you. So over to you first, Fiona, please.
Yeah, thank you, Chair. So as Anne just mentioned, there has been a starting of a concern around the level of activity and the impact to our staff and our patients. We probably just need to be mindful of that and keep an eye on it, but it's a first sign of it, so I'm not overly concerned. It may be other things. I suppose the 3 things I would pull out there in terms of the challenges is the deteriorating patient. So we have seen a jump in cardiac arrest incidents this month, but it may, as I say, not be a trend. It may be that we've just had some very, very sick patients and we haven't had a chance to have that end of life or resuscitation decision making conversation, and just need to encourage and support the teams to do that in a timely manner. The other is that we have had an increase in the incidents around discharge, and particularly missed or delayed or left behind medications. We've set up a safe discharge meeting, which one of my heads of nursing is chairing, and we have governor and patient forum members on that to support us to improve that performance or that experience of patients. and we look forward to seeing the output of that. But they're working hard on improving the checks and balances done at discharge. And the other is, I guess, increased activity, which we saw last month, but it continues around people with children in crisis, and also now, particularly this month, mental health adults in mental health crisis as well. You'll see that we're having included graphs and activity around the children in crisis and the number of actions that are being taken at system and local level, and we are seeing progress against those actions. I haven't included data and hadn't seen that it was in the minutes that you wanted, Chair, data on adult mental health, so I'll try and give you that for next month if you still want it. But it is the children that I'm most concerned about in terms of the impact to the organisation and to them. I think the adult mental health patients has been an ongoing issue and concern for us, particularly impacting on A&E. However, there has been ongoing actions being taken on that, so not less concerned on that. In terms of the new indicator that may have been a surprise to you today to have some commentary on was around Mssa Bacteremia, and I just wanted to flag that because one of the questions I had from one of my colleagues is, oh crikey, have we had an MRSA? We haven't had an MRSA bacteremia for over 3 years now, but nationally that means that we are now setting the target for MSSA, which are sensitive to Staph aureus rather than resistant. They can be caused by a number of different things. My commentary again, I hope you see it as assurance that the two that we've had, neither of them have been hospital acquired or on investigation seen any lapses of care associated with those. So again, good investigation, good analysis, but no lapses in care associated with their hospital stay. Otherwise, happy to take questions.
Thank you, Fiona. Any questions or perspectives to Fiona? Okay, I can't see any digital hands. I'd just like to build on some of the things we talked about this morning, Fiona, just for the public record. We talked about the fact that a number of our frontline teams suffered racist abuse from patients on occasion. I'd just like to make it very clear to members of the public, we will not tolerate any racial abuse of any member of staff in the trust, whether it's in the hospital or in the community. We have a red card system, which means if you continue to espouse racial abuse at a member of staff, we can refuse care. We take racial abuse of any member of our staff or any discrimination against any member of our staff with the most seriousness, and members of the public with those types of views should keep them to themselves and be grateful for the kindness and empathy which our staff all show when looking after them in their moments of need. Glenn, did you want to make another point?
Yeah, it was just on the infection prevention issue, Fiona, if I may. I mean, obviously there's a lot of talk in the media about, I think it's been referred to as Freedom Day, where some of the national guidelines will change. I think it's just worth emphasising for us that the stringent infection prevention rules that we've been applying over the last year, and indeed over many years, will continue. Our NHS guidance will continue to be much stronger than the guidance that we give to people living in the community. And I think we have seen an overall reduction in infections as a result of these more stringent guidance over the last year. So it's probably just worth reinforcing that visitors, patients who come into our care will still have the absolutely highest standards applied to them.
Yeah, thank you. I think that's a really important public message, actually, Glenn, because and partly linked to what you, Russell, said, because there will potentially be an expectation that they won't need face masks and protection when they come into hospital, but they will. We are expecting national guidance related to the NHS, which is going to be different to public other spaces, we would want them still to continue with that protection as they have been for the last year, as you say. Thank you.
Thank you, Fiona. Thank you, Glenn. So moving on then to Helen's report. Helen, what are the key things? Obviously a comprehensive update on cancer as well. What are the key things you'd like to put up?
Thank you, Russell. I think the report itself is reflective of the recovery across the elective services and the urgent care pressures that we've been seeing, a significant rise in those across the country. I think the positive elements within the report are relating to the Accelerator programme and some of the health inequalities pieces of work that we've done with the waiting list. I think the less positive elements of that are some of the performance we're seeing against the urgent care and some of the sustained increase that we're seeing in relation to cancer referrals. So I'll just take any questions.
Thank you, Helen. And I'm really conscious, as I know we saw yesterday in the F&P subcommittee, the fantastic work that's going on productivity, which is having a real underlying benefit of us being able to cope with this volume. Any questions or perspectives to Helen? Rosemary.
Helen, I wanted to ask about the deprivation indicators. Glenn talked earlier on about the Nuffield deprivation indicators and the importance of rural deprivation. I wondered if the figures that we're using for the Accelerator programme, do they reflect rural deprivation or are they more urban biased?
So what they're actually based on is postcodes which have the highest deprivation. So it's not particularly from a rurality point of view, because actually many of the patients that we see that live in the rural areas, they're not actually deprived in terms of that deprivation index. But what we are able to do is the codes, as you'll see, that's demonstrated in the report, you can then drill down. There's further reports that sit behind it that look at age, and they look at how long patients have been on the waiting list, they look at their ethnicity, and we can pull out the data in various different ways. If we wanted to look at it around rurality and frailty, then we could pull the data out that way. So the programme that the team have applied to the waiting list, we can explore that in many ways. The piece that we have had to do though is significantly linked to the elective recovery programme, where you are expected to be managing your waiting list around deprivation and some of the health inequalities piece. So we have done a piece of work around learning disabilities, been able to identify every patient on the waiting list with a learning disability, because we know their health outcomes are significantly worse than the general population, and all those patients are now dated. So and that's a really, really significant piece of work for us. Thanks,
Helen. Thanks, Rosemary. And Sue?
Helen, I know it's a complex.
Downship.
I know it's a complex picture on cancer, but when you state capability, could you explain whether it's clinical workforce, environmental space to hold the clinic, services, and which ones of those are the most substantial issues for us?
Space, particularly on some specialties, is a real challenge for us. If you think around head and neck and ENT, those teams have been unable to resume their normal outpatient work because of the the social distancing, some of the infection control measures. So we're not being able to see patients in the volume that we were because of aerosol generating procedures. And at the moment, we are unable to find a solution to that. So that is causing us a significant challenge. I think there are some issues when we say about capability, it's probably capacity, because the same teams that are recovering the elective position and managing the increase in the emergency surgical activity that we're seeing are the cancer teams as well. So they are equally stretched throughout elective recovery, cancer and emergency recovery. Many of these teams, and whilst we know we weren't doing elective surgery during COVID, were redistributed into other areas to do other pieces of work. So the staff are tired, and we're putting a lot of pressure on them to be able to deliver all of these really important metrics all at the same time. And so there is a challenge for us about how we balance all of those, but also how we look after our staff. I think there are some issues where we have, and this isn't a detriment to my clinical colleagues at all, because they're all a fantastic, very willing bunch. But as we've moved and we've lost a lot of our probably more experienced consultants who may be able to do 10 procedures on a list, some of our less experienced consultants may only do 7 or 8. And so we are losing something in terms of that productivity, hoping that they will get up to speed and are supported by some of the more experienced consultants. But obviously experience is a really, really important thing, particularly when you're trying to drive out some of that productivity. So I think it's almost a perfect storm of a number of things all together, Sue.
No, that's a helpful and comprehensive answer, Helen. Let's make sure, like we said this morning, we have a good workshop chunk on the issue so we can help you if at all possible. And finally, Bruce.
Thank you, Russell. Helen, a quick question on the page 46 of 277 or 16 of 63, depending on what system you're using. The top graph there, I'll forgive the average word, but it's meant to be indicative of how many beds we have full, as I understand it. Could you just explain what the indicative comment is? I mean, is this really a picture of where the beds are, or are we going to get a consistent undercall of the number, which I think from your comment, it's fuller than the numbers show?
Sorry, you talked about bed occupancy, Bruce.
Yes, the top graph on that page.
Yes, whatever system you were using, I struggled to find. So, yeah. So, no, we are not at full bed occupancy and haven't been for some time, as you can see. The pressure in the system is the different pathways that we have to use to maintain COVID safety. And okay. So where we are at the moment is that we are continuing to use Beecham. We would normally have Beecham closed. Beecham would have been closed months ago. The side room capacity for the organisation is massive, and we know that there are still multiple numbers of patients with various conditions, not just COVID, that need to be in a side room, and the impact of COVID on top of that means that we are using our side room capacity to absolute maximum, and our other bedded capacity cannot be used in the same way. And so it's really a reflection of, we have probably enough beds in the system, but we haven't got enough kinds of the right types of beds.
Okay.
There are some challenges with the pathways, particularly around testing, and some delays. You mentioned the pathology network, but there are some delays in some of the turnaround times of a number of tests and procedures that are also causing us some challenges to be able to get the patient into the right place at the right time.
Okay, thank you.
Helen, we're really conscious of how tough things are at the moment. Thank you for your leadership and hard work, and please pass on our thanks to your team. So we'll move on then to Gertie. Gertie.
Thank you, Chair. I will be brief. The report generally speaks for itself. There's probably 3 points I'd probably want to pull out for members of the public. One, which is that recruitment continues to be positive and we continue to attract colleagues into the organisation. We have seen an increase in the nursing vacancy in month, but we've equally seen an increase in our establishment, and we will continue to work to rectify that. In terms of sickness, it's positive to note that we're still seeing a significant reduction on the levels of sickness we've experienced over the past couple of years. Slight increase in April, but nothing compared to previous levels. And the final point I'll make, which isn't actually in the report, is to just reassure and to make members of the public and the board aware that the quarterly staff survey has now launched in the trust, and members of the public be aware that we're looking to have a much more regular feedback from staff about their experience and their well-being. The final point I'll close with, Chair, is that I'll be working with the teams to develop the presentation of the people and OD report moving forward, so members of the public may expect to see some changes as we embed in. Thank you. Happy to take questions.
Thank you, Gertie. Any questions or perspectives to Gertie? No, that's great. Thank you, Gertie. And so I think we move on to Kim. Kim, the finance report, please.
Thank you, Chair. So pleased to report that we've delivered a surplus of just over £109,000 for May. Our cash position also remains strong at £35 million. As I mentioned earlier this morning, actually, we're expecting further guidance about the funding arrangements for H2, and we'll be bringing back more detailed plans over the next couple of months to see what that means for us. I just wanted to really bring out that really pleased around the work that the informatics and the finance team have done in terms of developing a tool to assist in recovery, and really I think worked well in terms of creating a multidisciplinary team with Helen's operational team to work very differently around the recovery. And as a result, we have we've recognised an additional £1.5 million of the elective recovery fund in our position. We have offset that by expenditure as requested by NHS-IE for presentation purposes at the moment. But again, that couldn't have been achieved really, I think, without that joint working, which I think is really a real credit, really, I think, to the teams. So as that underlines really, I suppose, the productivity, and I know we've touched on this a couple of times, our reference cost that's just been announced for the 19-20 period is 86 compared to the national benchmark of 100. So you can see that significantly below national cost. And again, the productivity charts that are within the finance papers will demonstrate really that we're again the good work on recovery that the organisation has been working hard on. So those are the key things that I want to draw out today.
Thank you very much, Kim. Any questions or perspectives to Kim? Bruce, please.
Thanks, Russell. Kim, really love the new report. I think that's absolutely the sort of report that we need in order to keep a grip and fingers on all the pulses. And I recognise that it's really difficult at the centre of a large organisation to do so. But I'd encourage you to, keep going and develop this more, because my sense is it should be really useful for all the divisions and all the specialities where there is a particular pressure in particular. So thank you.
Thank you, Bruce. And Glenn?
Yeah, thanks, Kim. As you mentioned, we're in the rather unusual position of being in July now and not having a clear financial envelope for the second half of the year as an NHS, but also as a trust. So I think regardless of whether that guidance lands, I think probably next time we meet, we need to start to come up with some provisional plan for H2. We had the same conversation at Georgia earlier yesterday, because it's we can't move forward with that uncertainty, even if we operate in it as an organisation. We need the clarity for the clinical teams, particularly to continue to do the really good activity that we're getting through on the waiting list.
Okay.
Thank you, Glenn. And finally, Rosemary.
Yes, Kim, I wanted to bring out the capital changes, as noted in the capital program section, about the population health management system, which we were intending to buy and capitalise. Accounting changes mean that that's now going to be expensed. I'm hoping that somebody is in discussions with NHSI or X or whoever is funding it, so that the funding arrangements would be amended appropriately, that we would get some sort of revenue funding rather than capital going forward.
Yeah, we've had discussions with NHSI around the effectively the deferment of some of a part of the money that was given to us in capital terms for next year. So we're just filling in the paperwork to do that, but all seems positive around that carry forward, so we don't lose that capital sum. So that's positive. We have had to absorb really the issue in terms of a revenue hit, which is unfortunate. But as I said, but with the I suppose the recovery around elective recovery, we've been able to, you know, hopefully be able to cover that, although it's disappointing because it's clearly a national issue in terms of clarification really of the sort of international accounting standards change.
Thank you, Kim. Thank you, Rosemary. Colleagues, happy to move on? So, Scott, we've then got the Mortality Trust-wide report. Is there anything you'd like to pull out, or should we just take it as read?
No, just take it as read, Chair. Thank you. There's a 6-month report, part of that are missing, which were promised for the next meeting. I'm afraid it's fallen between the two stools of our old AMD for governance, who is Fraser Millard, and our new appointee, Pablo Garcia de Paso, who's really just picked up the reins in the last week. So there's an element of that which will be reported to the next board.
Thank you, Scott. So any questions on the Mortality Trust-wide report, which is still looking good? Okie dokie. So we'll move on then to the monthly safe staffing report. Fiona.
Yeah, thanks, Chair. So this is your normal monthly staffing paper, which is a requirement to come to board, and includes a number of KPIs that give assurance that our staffing is robustly overseen and monitored, and that assures the board that patient care is safe. There's a number of areas that are in our risk register related to vacancy or sickness or maternity, and that includes the children's community team, who are out to advert with a big social media campaign to improve their vacancy position. Equally, health visiting doing the same, and theatres doing the same. So they're the three hotspots that are on our risk register, are causing some concern, but we've got actions in train to improve that position.
Thank you. Any questions or perspectives to Fiona? Fiona and Kim, I don't mind if you come back to me on this, but it relates to safe staffing and agency. On our agency usage,
yeah,
what percentage of the agencies that we use are tier 1 agencies? So if you may want to come back to me on that, which I'm happy to, but I'm asking the question elsewhere, and I'd quite like to know the answer here. So it's a percentage of the agencies, the nurse agencies we use, which are on tier 1 caps. Okay. Leave you to come back.
Thank you.
That's okay. So moving on then, the Audit Committee summary report for the 2nd of June. Anything you want to pull out, Rosemary, or do you want to take as read?
No, I'll take it as read because it's a summary. I actually gave a verbal summary at our last board meeting.
Thank you, Fiona. Any questions to Fiona on the 2nd of June Audit Committee?
Or even Rosemary.
Sorry, Rosemary. You can do it if you want to. If you want to do it, you can do it. Thank you, Rosemary. Okay, so we'll move on then to the Clinical Governance Committee report from the 8th of June, which Jeff kindly chaired. Jeff, anything you particularly want to pull out?
Report as read, Chair. Thank you very much indeed. I would just commend the Falls deep dive analysis, which was an excellent piece of work, came to committee. We've actually asked them nonetheless, the Falls to come back sometime in the future to look at falls in the community as well, so that we can get a cross-trust picture of the whole piece. But other than that, just take the report as read. Chair, say questions.
Thank you, Jeff. Any questions to Jeff on that committee report? Thank you, Jeff, for standing in for Bruce. So we'll move on then to the F&P committee report for the 1st of June. Simon, anything you particularly like to highlight?
Thank you, Chair. Nothing to highlight, Chair. This is, I verbally reported on the meeting at the last board meeting, in fact. So happy to take questions.
Okay. Any questions to Simon? Simon, just so you're aware, I do get feedback from governors who have been attending that meeting, which is really positive feedback about the quality of debates that are going on there. And I know you've mentioned to us before the assuring work which is going on behind the scenes between Helen and Kim's team on productivity, so well done. Okay, so we move on then to the Council of Governors report from the 13th of May, which I'll take as read. Any questions on the Council of Governors report from the 13th of May? Okay, thank you, Meg, for pulling that together. So we've then got the capital programme. I apologise, Bruce.
Sorry, Russell, slow technology. Can I add, because it's factually correct, that the CCG, the assurance paper on clinical governance, was indeed presented to the Council of Governors. It's been inadvertently omitted. Thank you.
Thank you, Bruce. Let's make sure we minute that. Okay, colleagues, happy to move on then to the capital programme quarterly update. One of the issues we've got going forwards is how much control we've got over our own capital spend, which Glenn is on like a hawk. But Sophie, how are we doing at the moment?
Thanks, Russell. So it continues to be a very busy capital year. There's no calming down. This paper sets out an overall increase in our programme due to the elective recovery and some capital we secured through a bid that Helen did around supporting us with our day surgery work to enable us to open up all of our theatres again. We're also touching on what Glenn spoke about earlier around the Community Diagnostics Hub. We are expecting further capital to support some of the pieces of work we're going to do over at Stratford. So the programme continues to grow throughout the year, and we're having to be flexible and kind of adapt to that and those timescales that we're faced with to complete some of those projects. Just a couple of points on capital schemes. So the first is just around the surgical assessment unit. So I think it's just worth pointing out to board that is one of the key elements of the winter preparation plans that Helen's got in place with her teams. It's actually becoming a very difficult project to complete. So we're having to put our thinking caps on to see if we can find an alternative option for that. So it's currently on the capital programme. That might be one that changes quite quickly. And then the final one, thanks to Mike Wells for pointing out, there is an error on one of the appendices around the Ellen Badger. So it says it's due to start in January 23, but it's January 22. So other than that, I'm happy to take questions.
You never know, Sophie. You never know.
I know.
Any questions to Sophie on the capital programme? Glenn?
It's probably worth mentioning, Sophie, that there are so many moving parts in this capital programme, with potentially the IT transfer as well as a project to increase our training capacity, which is probably something we'll bring back to the next board meeting for approval, I imagine. Yeah.
No, absolutely. Okay, thank you, Glenn. Thank you, Sophie. No, it's not an easy programme to manage. Colleagues, happy to move on to the Board Assurance Framework and Risk Quarterly Report. So, Anne, back with you.
Thank you, Chair. So the Board Assurance Framework, there's a number of different points to pick up here. We've got the 2021 end of Board Assurance Framework that's presented to agree that end of year position. We have the 21-22 back is also presented. Also included for information are the red risks on our divisional risk registers. Those are attached for information. Internal Audit have undertaken a final review of our BAF for 2020-21. and we have responded to those internal audits in terms of the format of the individual risks. So that will be that has been taken account of in this year's BAF. We are also have considered the internal audit actions in terms of how that might connect in with our risk management refresh, and we have further internal audit review of divisional level risk management. And all of this then starts to pull into our risk management strategy for the organisation. It was due for review in January 2022. But what that will be built on really is the internal audit reviews, the reviews of BAF, the reviews of our divisional risk register, the internal audit recommendations, and that will accumulate in board of director workshops, which will be a real focus on risk management. The first in September 2021, sharing a diagnostic update on BAF, on our risk appetite, the work we did earlier on the year in terms of Black Swan event, so that can hopefully shape risk management strategy. And then coming back in 2022, just understanding our action plan and work underway and our progress on implementation of best practice. So a lot of work underway in terms of risk management and review of our processes.
No, thank you, Anne, and very important work too to ensure we're able to provide safe service to those that we look after. Any questions or perspectives on the BAF? Please raise a digital hand. Okay, very clear. Well done, team. So we move on then to the summary of ratified policies, including the clinical photography and video recording policy. One key thing missing is the I only like to be shot on the left side of my face, never the right side. So, yes. Anything you want to add to these two policies, Anne?
No, not at all. Happy to take any questions on both of these.
Okay, any questions from colleagues? Okie dokie, thank you very much. And then we're on to the appointment of consultants. Gertie?
The report speaks for itself, Chair. I have nothing to add, but happy to take questions.
Okay, great. Any questions to Gertie on the appointment of consultants? Okay, so I think we're then on to the Equality and Diversity Annual Report, Health and Safety Annual Report, and Security Annual Report. These are for noting. Gertie and Helen?
Could I say something, please, Chair?
Of course you can, Helen.
Yeah, particularly around the Safety and Security Annual Report, just want to particularly draw the board's attention to the work that is going on within that report around violence and aggression towards staff, whether that will be physical or verbal abuse, including the work that's ongoing around racial harassment and abuse. And I suppose this has been ongoing for some time, but it is important to note that we have an ongoing red card system, as you have said, and we do prosecute people for numerous things for patients and visitors who abuse or harass our staff, and you'll see some detail of some of the ongoing anonymised reports in there, and we do have a current prosecution ongoing for racial abuse and harassment to several members of staff. Thought it was pertinent to bring the board's attention to that work, that there is work ongoing. We probably just don't highlight it quite as much as we probably should do.
Okay, that's great. And did you want to add something to that, Gertie?
Yeah, if I might, Chair. I mean, you've already mentioned we had a really powerful discussion this morning and some real passion from the board to do much more to improve the experience of all of our colleagues. The report is very detailed. I don't intend to go through the detail of it, but I think it's really positive to see the partnership working internally with networks and externally with colleagues in areas such as EQUIP. We will be working much more collaboratively across the group, developing networks for networks in future and building a really positive response to the current leadership for inclusion development that's going through the board. So we will hope to see more positive work coming forward and sharing with the board in future, but thank you.
Okay, great. Thank you, Gertie. And other comments or perspectives on the 3 reports, Rosemary?
Yes, thanks, Russell. And a great sessions this morning. But one point which comes out of the report on the quality regarding the recruitment data, I thought it's an interesting statistic about recruitment by gender profile. Implies that there may be a bias towards female recruitment. And I just was surprised at quite how biased that was compared to the number of candidates. And I guess it's just something which we'd like to see that our eyes are open to and understand the reasons why that is.
Okay, maybe take that one. Thank you, Rosemary. And Sue?
Yes, just to say that it was a really useful session this morning, and that Gertie, I absolutely agree that bringing back the new EDI strategy, because I note that this one runs out this year, as it were. It's really good timing. So if we can understand as the board inclusion work, development work concludes, if you can set out a timeline for us on when we will be working on which pieces, that would be really helpful.
Yeah. I think one of the other things that came out this morning, wasn't it, was around, whilst we might have a set of values as an organisation, part of the living of those values is when there are moments of truth where racism or other discrimination is occurring, that we stand up beside our colleagues and call it out and support our colleagues. So it's important to be not only seen to talk the right talk, but truly to walk the walk and to stand up and support our colleagues when they need our support. Any other questions on the 3 reports? These are all for noting. Everyone happy to note? Okay, thank you very much. A lot of work's gone into those, so thank you everyone involved. We've then got just some committee minutes to note again. The first is the Audit Committee, the 19th of May. Rosemary, seems like a long while ago. Anything you want to add?
Nothing to add.
Thank you, Rosemary. Any questions from colleagues? Clinical Governance of the 12th of May. Bruce, anything you want to add?
Nothing to add. Happy to take questions.
Okay, great. Thank you. And the NED, the Finance and Performance Committee, the 4th of May. Simon, anything you want to add?
No, nothing to add. Happy to take questions.
Thank you. Any questions from colleagues? Okie dokie. So I think we're on to any other business. Digital Hand team, if you've got any other business. Sue?
Chair, I wasn't quick enough at the beginning of the meeting. If we could take your mind back to matters arising, I think there is one that's missing off the schedule. Last month in Glenn's Chief Executive report, we agreed that the board would invite the Pathology Network to come to NED F&P and share their recovery plan for 28-day diagnostic performance. So that needs adding. Okay,
apologies, Sue, if I didn't give you time at that point, but let's make sure we do that. And Glenn, let's make sure, or Simon, that we invite them. Helen, did you want to come back on that?
Yeah, it's actioned, Chairman, I've done it. Okay,
great. Super, thank you, Helen. How quick is that sort of pace of productivity? And Sue, is that still a legacy hand? Okay, any other business team? Okay, great. So I think we're then on to questions from governors and members of the public. If any member of the public wants to ask a question or a governor, could you please raise a digital hand? I can't see any digital hands, so if Roger.
Thank you. Yes, I did send in a couple of questions. The first is the Chief Executive confident that SWFT will be allocated sufficient resources from the system finance allocation to enable SWFT to continue to work and deliver healthcare in outstanding mode?
Glenn?
It's a really good question, Roger. I mean, firstly, we definitely benefited from the previous methodology where there was a standard tariff for activity, because our productivity has always been one of the best in the NHS, hence the stats I was quoting earlier. And if we were still working to a national tariff system in that way, we'd have £25 million to invest in improving our services. So I would be wrong to say we wouldn't be better as a consequence of having access to that 25 million, because we certainly would. However, the way forward is for us to work much more in systems, and therefore the resources at the moment are being directed a little bit more towards where money is being spent, not necessarily linked to productivity. So we need to work really closely with system partners to make sure that we improve productivity across the system, so that we can all benefit from the growth monies that are available to the NHS, because at the moment the growth money will go to those who are spending more rather than those necessarily who have greater need. That said, we've got incredibly innovative staff. We continue to improve our productivity, and so we still manage to continue to improve our services despite slightly more constrained financial performance. So I suppose I'm saying that the framework itself isn't as favourable to efficient organisations like ours as it was in the past, but I've got every confidence in our team that we can continue to hold our status as one of the best performing trusts in the NHS.
Yeah, I would just add to that. There is a danger in the new financial regime that there is effectively a doubling down of expectations of performance rather than an aspiration and an incentive to perform better. And I hope when the detail comes out, there'll be more incentives to perform better, which we will benefit from because we are one of the better performers. And your second question, Roger?
The second is almost in relation to the last paragraph of both your comments. Is there pushback on sharing best practice by UHCW, allowing that the weighted activity unit system shows SWFT to be significantly more efficient, showing best practice, than UHCW?
Yeah, I don't want to get into too much of a comparison with friends on our patch. What I would say is I do hope the integrated care system leadership takes an independent perspective and challenges all the different elements of the system to an exemplar status, rather than the potential danger of, because one part of the system has got a problem, all of the focus is on saving them and sorting out or accepting their poorer performance. So I'm by nature an optimist, and I think given the changes in leadership at the ICS level, which will be occurring, have been occurring recently, will occur over the next few months, I think we need to hold our breath at the moment a bit on that.
Thank you.
That's a politician's answer, Roger. And any other questions from members of the public or governors? Okay, well, we look forward to seeing you at the next board meeting, and we are sorry that we're not going to see you at tomorrow's AGM, but we look forward to seeing you on the 4th of August. Board colleagues, I suggest we now have a 10-minute break. We get back together again at 3:25 for the confidential board. Thank you.